Okay, hello, good evening. Today we are going to discuss the second session about breast and endocrine surgery. We finished about half the question, MCQ, eMRCS, in our last discussion, and we will continue again to finish today, inshallah. Okay, I think we stopped at I think question number 17. It was last week and repeated again, no problem. Okay, so we can start now.
We did that.
Okay, I think should start Dr. Ghada Sabah. I think she's offline. Okay, so we can start with Dr. Ghada next and Dr. Fatima and continue our team. Okay. We can start now. Okay.
Okay. 43-year-old woman had recurrent episodes of breast infections, and she has received multiple courses of antibiotics and is troubled by persisting green nipple discharge. Clinical examination reveals green nipple discharge but no discrete lump. Imaging with mammography and ultrasound is reassuring. U2, M2. What's the best course of action? Undertake Hatfield procedure, undertake microdocotomy, arrange breast MRI scan, express fluid for cytology, prescribe danazole. So it's U2 and M2 and it's reassuring. With recurrent infection, first option, undertake Hatfield's procedure to remove the dilated ducts.
Okay. Exactly. Doing Hatfield operation is one of the operations we do for ductectasia. We have two scenarios we'll meet here and during our discussion about this topic about ductectasia. One of them, or I can see it just similar discussion or similar question or related question. One of them, he will tell you female patient, young also, and she have just one episode of crazy or green pasty discharge, and on examination and investigation, she is completely free. And this will go for just conservative treatment or just follow-up, no intervention, reassurance, exactly. The other scenario is what we are facing now. She has received multiple courses of antibiotics or multiple trial of treatment, but she still have persisting green nipple discharge. Maybe sometimes we don't find discrete lump, and sometimes we find what's called like something fusiform lump, like a elliptical lump or something like this, starting from the nipple and areola, more palpable, or sometimes, and I did see it, you can see it like bulging at the areola space. So please, anyone please mute himself if okay. And so we hear because failure of medical treatment and it is a disturbing or recurrent problem, so we have to go for surgical intervention, which is Hatfield's procedure. Microductectomy is a procedure we use for duct papilloma, which is a bloody nipple discharge. Sometimes we do what's called I just forget. We do like
Bone resection.
no, I'm just talking about investigation we do for the
Lab sticks.
left papilloma.
Lab sticks.
Some lab stick for to make sure that's blood, and sometimes we do like fistulogram or something like this. What's called ductogram. Sorry. Sometimes we do the ductogram. Yeah, sometimes we do ductogram. So before we do, to just determine which duct is we need to remove, and we do what's called microductectomy. Okay, I think this is the two scenario we will face here.
Okay.
Okay, next question.
A 48 years old lady undergoes a redo thyroidectomy for multinodular goiter. 24 hours post-operatively, she develops oligogyric crisis and diffuse muscle spasm. What is the most appropriate course of action? Arrange CT scan of the head, administration of intravenous magnesium, administration of intravenous calcium, return the patient to the theater for wound exploration, call in anesthetics to paralyze and ventilate the patient. Okay, so is administration of intravenous calcium?
And so what you expect the problem?
Because they did the thyroidectomy, so they might have removed the parathyroid gland as well. But it's like
okay.
24.
So you expect a problem in the parathyroid gland, whatever the problem. Okay, and this is maybe ischemia or relative ischemia, or maybe removed, accidentally removed. So we are giving an intravenous calcium. Okay.
Yeah.
I think this is clear. This is a hypocalcemic tetanic attack, muscle spasm, sometimes tightness in chest, muscle weakness, difficult breathing. All this you can see clinically in a patient with hypocalcemic attack. Okay, and it's a very common problem after thyroidectomy, and here I think it is redo thyroidectomy, so it's a difficult operation, what's called nightmare for surgeons. So it's very common that you can make devascularization or relative ischemia, or even remove the parathyroid gland. Okay. Next question.
A 32-year-old lady has previously undergone a wide local excision and axillary node clearance, 5 nodes positive for an invasive ductal carcinoma. It is estrogen receptor negative, HER2 positive, vascular invasion is present. She has a lesion suspicious for metastatic disease in the left lobe of her liver. Of the agents listed below, which is the most likely to be beneficial in this setting? Cetuximab, bevacizumab, transumab, basiliximab, imatinib. As it is HER2 positive, cetuximab.
You mean A?
Yes, sir.
Okay. Anyone has different answer?
C.
Dr. Fatima C. Dr. Ibrahim C.
Trastuzumab.
Dr. Ghada Trastuzumab. Yes, exactly. Here we are talking about HER2 positive patient. We did the operation, and we are talking about what is the biological agent we are going to give after the analysis, which is the, for HER2 positive patient, we give trastuzumab. Okay, give trastuzumab. According to the pathology report we receive after the operation. Okay, we are looking to, I did say this last time, you are looking to the hormone, estrogen and progesterone receptor, positive or negative. Okay, and you're looking to the HER2 receptor, and you are looking to the Ki67. Okay, Ki67 you will not find any question about, and what we are facing now questions, or he will ask you about the estrogen and progesterone receptor, positive or negative, and he will ask you about the HER2 positive or negative. Okay, and also we are talking about the lymph nodes, positive or negative. What he is talking about, lymph node, he wants you to know that if the patient is lymph node positive, you have to give chemotherapy. Simply, he don't want you to be a professional breast surgeon. He just wants you to know simple words or simple informations. Lymph node positive equals chemotherapy. Okay. Estrogen and progesterone positive equals, look to the age of the patient. Okay. If the patient is premenopausal, okay, and he will mention this in the scenario if he wants you to differentiate between the answer. If the patient is premenopausal, you go for tamoxifen for 5 years. If the patient postmenopausal, you will go for aromatase inhibitor, like anastrozole or something like this. Okay. If the patient is HER receptor positive, HER2 positive, you will go for trastuzumab. Okay. Or sometimes he tell you Herceptin. Sometimes in the question is Herceptin, and sometimes trastuzumab. Sometimes he tell you the patient has positive lymph node and HER2 positive, so you will give Herceptin plus chemotherapy. Or estrogen and progesterone positive, and the patient has positive lymph nodes, you will go for tamoxifen or anastrozole or tamoxifen aromatase inhibitor. Okay, and chemotherapy. By the way, this is a very frequent question in recalls, and you just have to put in your mind. Simply 3 words: lymph node equal chemotherapy, estrogen progesterone equal aromatase or tamoxifen, HER2 equals trastuzumab or Herceptin. Just these simple words keep in your mind, and you'll find it's easy to find your answer in the question. Okay, clear?
Yes.
Okay, Dr. Mahmoud Abdul Ghani, can he wants to ask, raise hand, or just it was?
No question from me for continuation.
Sorry?
No question.
Do you want to ask?
No, it's
okay,
clear for me.
You. Okay, thank you, Dr. Mahmoud. Thank you. Okay, who's next? Dr.
Yes.
Ismail and then Dr. Ibrahim. Okay.
Okay.
Just this is simple to remind you about some biological agents. You don't have anything here important except for the question also here. This about Crohn's disease, by the way. Sometimes you face this question. Mostly he will give you infliximab, very common in exam in question. Etanercept and Adalimumab, not very frequent. It's mostly in question if he want to ask you about a biological agent for Crohn's disease or inflammatory bowel disease, he will ask about infliximab. You'll find it in the answer. The other one is trastuzumab, which about its hair receptor in breast cancer. Others is not very common in the exam. They don't have questions about here. Okay, this is the most common repeated 2 drugs you'll find in your exam. Okay, next question.
Okay. Which blood test is most likely to be helpful in following situation? A 20-year-old lady has undergone a total thyroidectomy for a well-differentiated papillary carcinoma. She attends clinic and is well, and the surgeon wishes to screen the disease recurrence. Calcitonin, antibodies to TSH receptor, antibodies to parafollicular cells, thyroid peroxidase inhibitor antibodies, thyroglobulin antibodies. The answer, thyroglobulin antibodies.
Cyroglobin antibody.
Papillary carcinoma.
Okay. Any different answer? I see someone write D.
Oh, sorry, it's E. Yeah.
It's a yes.
I noted by mistake. Yeah.
Okay. Yes, exactly. Cyroglobin antibodies is the most common screening test for after total thyroidectomy. By the way, for most cancers or even after total thyroidectomy for any cause, because thyroglobulin is only manufactured and released by the thyroid gland. When you completely remove the thyroid, you should have level 0 thyroglobulin, I think, within few days. And if any rise any time, so you have an ectopic thyroid tissue or incomplete removal or recurrence, if any cancer or tumor or metastatic lesion. Okay, so thyroglobulin, put in your mind, it is only, this protein is only produced by thyroid gland. When you remove the thyroid gland, you should have 0 thyroglobulin in your blood and thyroglobulin antibodies as well. So this is one of the best screening tests after total thyroidectomy. Okay. I think we mentioned one antibodies or antigen. When you completely remove an organ, if you want to test for recurrence, you do this test. I think we mentioned it in one of our branches we studied before. Anyone remember a related question like this? Is this a screening tissue for some antigen after removal of an organ related to urology? Anyone remember?
PSA.
PSA, exactly, perfect. PSA, when after total prostatectomy, you are doing the screening by PSA because this antigen is only produced by the prostate, and after total thyroidectomy, the level should decrease, I think, within 1 week to the level 0, and any further increase, it should be considered as recurrence. Okay.
Okay.
This also is important. This we will face during our scenarios. First one is thyroid peroxidase antibodies, and this is very helpful in autoimmune diseases like Hashimoto thyroiditis. You are confirming the diagnosis by this test, by the way, to make sure that is thyroid peroxidase antibodies. This is Hashimoto thyroiditis, okay? And this sometimes differentiated from hypothyroidism or any other cause that you make the test for thyroid peroxidase antibodies, because it's very high in Graves' disease or Hashimoto thyroiditis. Okay. Cyroglobin antibodies, I think we discussed about. And the last one is very, very important, very, very important and specific for medullary carcinoma. Okay.
Okay.
Very specific for medullary carcinoma, for screening and for recurrence, by the way. For screening, when, as we said before, medullary carcinoma, we have two types, the sporadic and the familiar type, okay? And we said the difference between both of them. The sporadic is mostly unilateral and district nodule and just single nodule, but the familiar type mostly will be an early age and will be bilateral and multifocal. And one of the screening tests you do is calcitonin. Okay?
Okay.
Next question.
A 23-year-old lady has Graves' disease that has replaced on stopping antithyroid drugs. Radioiodine is offered as the next treatment by the endocrinologist. Which statement is false? Graves has relapsed, sorry. Close contact with children is not permitted for up to 4 weeks following treatment. 15% of patients with ophthalmopathy will see worsening of eye signs. Symptomatic improvement takes 6 to 8 weeks. Up to 80% of patients will become hypothyroid. It increases the risk of parathyroid carcinoma. I guess E, it increases the risk of parathyroid carcinoma.
Okay, so everything about radioactive iodine, sorry. Radioactive is offered as the next treatment by the endocrinologist. Yeah, everything about radioactive iodine in a patient 23 years old. Just put this age in your mind, because they are not preferring to give young age, and they tell before 25 years to give any radioactive iodine unless it is the last hope, because it's claimed to be carcinogenic, I think in the 4th or 5th decade. Okay. They say more than 10 years. Any patient exposed for radioactive iodine or radioactive material, it is carcinogenic, so it is not preferred in young age. So I think the right sentence here will be it increases the risk of thyroid carcinoma. Okay, or any other cancer as well, as I remember from my study and my master, because just exposure to radioactive iodine in the neck is highly carcinogenic, especially more than 10 years from exposure. Okay, so here is, it is right in all except for it is increase the risk of parathyroid carcinoma. Okay. Next question. I think Dr. Ghada, start again with Dr. Ghada.
Okay. Which of the blood tests listed below is most likely to be abnormal in a 33-year-old lady present with a recently diagnosed goiter and the diagnosis of a Hashimoto thyroiditis is suspected? TSH receptor antibodies, thyroid peroxidase antibodies, Thyroglobulin antibodies, antibodies to parafollicular C cells, calcitonin, thyroid peroxidase antibodies.
Okay, I think we just discussed about it.
Yes,
Okay, this is
in the
one of the
last
most
table.
indicators. Yeah, most
Yes.
indicators about suspicion of Hashimoto's thyroiditis. And sometimes
Yes.
Graves' disease is thyroid peroxidase antibodies. And
Yes. TSH receptor antibodies, I think, for Graves' disease, mostly.
it's more for Graves' disease, but also
Yes.
thyroid peroxidase antibodies is elevated.
Also
I
present
think
in
read about
70%.
70% in Graves' disease, but
Yes.
100% in Hashimoto's thyroiditis.
In Hashimoto's.
And here we are just talking clearly about he wants you, this is what is the most suspect and what is the best
Yes.
answer. Okay, so we are going to thyroid peroxidase antibodies. Okay.
Yes.
Again, this table, just to remind you that thyroid peroxidase is 70% in Graves and 100% in Hashimoto, and he will not make you confused in the exam. It will be clearly, you should, or just for the exam, just expect it. Thyroid peroxidase related to Hashimoto, TSH receptor antibodies related to Graves, cyroglobulin related to complete thyroidectomy, total thyroidectomy, and calcitonin is related to medullary carcinoma.
Yes.
Okay, we are just dealing with broad lines. Just not confuse yourself by some variation or minor variations. Okay, next question.
42 years old women present with goiter. On examination, goiter feels lumpy. The blood results reveals TSH of 12 and free T4 of 2. Antithyroid peroxidase antibodies are high. What is the most likely cause? Multinodular goiter? No. Graves' disease? No. Hashimoto's? Yes. Euthyroid syndrome and poor compliance with thyroid medication. So let's see.
Let's see, Hashimoto. I think clear again. He repeats the question by different ways, just to confirm the idea about antithyroid peroxidase antibodies is related to Hashimoto disease. Okay, I think we said also the type of tumor produced by Hashimoto thyroiditis.
Yeah, lymphoma.
Remember?
Lymphoma.
B-cell lymphoma.
Lymphoma.
B-cell lymphoma, exactly. Okay, next question.
A 28-year-old female presents with painless lump in the upper outer quadrant of her left breast. Imaging using ultrasound is indeterminate U3. 2 core biopsies have been performed and both show normal breast tissue. What is the most appropriate course of action? Arrange for imaging surveillance at 3-month interval. Undertake a wide local excision of the lump. Reassure the patient and discharge. Undertake an excision biopsy of the lung. Arrange for breast CT scan.
What do you think?
2 core biopsies have both show normal breast tissue.
Yes.
It can
So
be
we can
excisional biopsy or the surveillance at 3 monthly interval. Both
3 months monthly interval surveillance.
you choose surveillance every 3 months. Any other opinion? Dr. Fatima, Dr. Ghada, Dr. Ibrahim.
I think excisional biopsy
For
and
first look,
concordant features are finding.
Yeah.
So in ultrasound, it's U3, completely benign. And there is another finding, it's B1, so not concordant. I think excisional biopsy is an option.
Okay.
Like one or for any of them.
Okay. This she is almost 30-year female. Okay, and she has a lump. I'm telling you, maybe in practice, that's why they talk, because they say from 15 to 25, sometimes you don't take a biopsy unless this is highly suspicious, especially if they found that it is slippery mass or highly mobile mass, because this is the age of fibroadenoma. And they go for, after the ultrasound, even if benign, just to confirm, the ultrasound is to confirm it's fibroadenoma, by the way, and then they go for excisional biopsy. Okay, but here's he talked to biopsies because she's 28, almost 30, so he have some doubt to take some biopsy. But the only rule for completing your exam here is he's continuing the investigation by the excisional biopsy. No rule for the CT here. He did already ultrasound. He did already invasive investigation, which is the core biopsy.
Core biopsy.
Okay, reassurance, it is unlogic. Undertake a wide local excision. You have no confirmation. You can't do this crime for as you don't have a proof it's something malignant, so you can't do wide local excision of the lump. This is a crime. You don't have a document. You don't have any proof that it is malignant. So we have surveillance. I think 1 and 3 are the same. Reassure the patient discharge. This is the same like surveillance every 3 months. It is unlogic, and we discussed this last in our first session about it is unlogic to give the patient. You have a mass and suspicious. You have to come every 3 months to make an ultrasound. So it is psychologically for the patient is it's not good. And what you are waiting for, you are waiting to see any manifestations of malignancy or any transformation to malignant features, so you can intervene. No, the logic is to go for excisional biopsy and to cut the doubt about this mass by approved histopathological test. Okay, and if this is in practice, by the way, whatever the age, 15, 18, 20, and you have a mass, as you palpate the mass, so it is more than 1 centimeter, so you have to go for excisional biopsy. Don't leave a mass in a female young age, because she has a long life expectancy. I'm talking about in your life as a practice. This mass, if she started at 18, and you will for sure maybe by in the 4th decade or 35, 40, this mass will be highly suspicious for malignancy. Okay.
Instead of co-needle biopsy, can we directly go for excision biopsy?
Sorry, you go? Excisional biopsy. You don't have, yeah. Sometimes
instead
in
of
some
doing
surgeon
a co-needle biopsy, can we directly go for an excision biopsy?
Exactly. If the mass is small and you can, it is in the ultrasound, it is well circumscribed and you can remove it. Why didn't go from the start for excisional biopsy? But I think maybe some policy more than 25 you have to go for, because I think before this age, from 18 or from 15 to 25, it is mostly we go direct for excisional biopsy, especially if the mass is small and you can remove
Okay.
it completely without any breast disturbance. Okay, next question.
Yes, sir. Okay.
Okay, a 38-year-old lady has undergone a mastectomy and axillary node clearance for invasive ductal carcinoma. The histology report shows a completely excised 3.5 centimeter lesion, which is grade 3. 2 of the axillary lymph nodes contain metastatic disease. The tumor is estrogen receptor negative. What should be the next course of action? Axillary radiotherapy, administration of cytotoxic chemotherapy, chest wall irradiation, administration of letrozole, surveillance alone. طيب. Administration of cytotoxic chemotherapy.
Okay.
هو الراديشن هنا مهم لكن مديني خيارين auxiliary radiotherapy just for irradiation. But I
It is
think
not axillary radiotherapy. He is clear here. He didn't want to confuse you. He didn't want to confuse you, and he said axillary radiotherapy. And we don't give radiotherapy for the lymph nodes.
Okay.
Anyone has different answer, or Dr. Fatima, Dr. Amouj, Dr. Ghada, Dr. Ibrahim?
It's chemotherapy. It's a positive axilla and completely excised lesion. So chemotherapy, it makes sense.
Yeah, B.
Yes, positive axilla. And it is estrogen receptor negative, so no need for aromatase inhibitor, even for her age. She's premenopausal. So
Yes, B.
chemotherapy, yes, B.
They can write the
I think
radio chemo as well, right?
Okay. Sorry?
Instead of cytotoxic chemotherapy, can they write a radio chemo as well?
Can be. By the way, all the answers here, you want to make it you want to make it far away from your thinking. The only respectable answer here may be if he said breast radiotherapy. Sometimes after excision of any mass in the breast, you give localized radiotherapy for the breast, not for the axilla. The radiotherapy is for the chest wall, not for the axilla. Put in your mind, for the axilla, we give lymph nodes, we give chemotherapy.
Chemo.
Chest wall irradiation, not, maybe, but I think no, it's not. If you are going to give a chemotherapy, no way. It is here is clear that he likes to give a radiotherapy after wide local excision without lymph node. He always tell you that we give radiotherapy to the breast after wide local excision as a complementary treatment, because it's proved that gives the same result for the same as complete mastectomy or radical mastectomy. They make wide local excision plus radiotherapy. Administration of letrozole, no, she is negative and she is premenopausal. Surveillance, no, for sure. So administration of chemotherapy is the most acceptable treatment. Radio chemo maybe, but chemo is the most important. Okay?
Okay.
Okay.
A 19-year-old male presents with bilateral gynecomastia, poor vision, and nipple discharge. Which of the following blood tests is most likely to be abnormal? Prolactin. D.
Okay. Poor vision and nipple discharge. So what do you expect the problem in?
Pituitary adenoma.
Most probably yes, adenoma. So prolactin, and she's young age, and she have a bilateral gynecomastia and poor vision and nipple suture. So prolactin is most probably. So what do you expect for the vision here to be?
The pituitary adenoma affect the optic chiasma, and this may lead to bilateral temporal hemianopia. Temporal hemianopia.
Exactly. Perfect. Upper or lower?
Upper.
More.
And the craniopharyngioma cause lower.
I think the reverse. It's compressing.
هي compressing اللور fibers بتعمل defect في الفيد the reverse.
Upper, exactly. And compressing the upper fibers will make the
So I guess the pituitary compress the lower fibers, and
pituitary compress the lower, and the craniopharyngioma compress the upper fibers.
Yes.
Exactly. Yes. Yes. You're right. Okay, because some objections about this, they will tell you it will give bitemporal hemianopia, but more on the upper or lower field. Okay, in the exam it will come like this. Next question. Okay, I think Dr. Fatima left. For anyone wants to participate, just raise hand. We can add them as well. Okay. Okay, Dr. who's there? Dr. Ghada.
Okay. 28-year-old female presents to the general practitioner with symptoms of fever and diarrhea. As a part of her diagnostic evaluation, the following thyroid function tests are obtained. TSH is less than 0.01, free T4 is 30, and T3 4. What's the most likely interpretation of this situation? Hypothyroidism, factitious hyperthyroidism, and anxiety state, sick euthyroid hyperthyroidism. TSH is very low and free T4 is very high. It's thyrotoxicosis, hyperthyroidism, E.
So you said hyperthyroidism. So we are TSH is low.
And she has a history of fever and diarrhea, which is solid findings in hyperthyroidism.
So you choose E or A?
No, E, hyperthyroidism.
Okay, I think I guess it's a yes, exactly.
Yes.
Fever and diarrhea, and this is one of the symptoms, or some of the symptoms of hyperthyroidism. And here the TSH is low and T4 is high, so it is hyperthyroidism. Okay. About sick euthyroid syndrome, it will be clear in the exam. Patient admitted hospital, post-operative, post-accident, or in ICU. And he will give you all the parameters is low. T3, T4, and TSH all are low. So this is the sick euthyroid syndrome, by the way. Okay. The question
Yes.
about sick euthyroid syndrome will be so clear. All parameters are low. All the parameters are low. So all parameters are low, and he will give you the patient is sick in hospital, mostly hospitalized patient. And he tells, sometimes he'll tell you, mostly he'll tell you he's in ICU or HDU or something like this. Okay.
Yes.
Yes.
Next question.
A 64-year-old obese female presents with a breast lump. She was hit on the breast by a cricket ball when playing with her grandson. What is the most likely explanation? Invasive ductal carcinoma in situ, fat necrosis, fibrocystic disease or ductectasia. So she is a obese female and a history of cricket ball. She was hit by a cricket ball on her breast. So she has a typical history that points towards a traumatic lesion, which is fat necrosis.
Okay, so you choose fat necrosis.
Yeah, because of the history.
Okay. Simply and direct, don't confuse yourself. No other data in the scenario that can direct your thinking about cancer or carcinoma
Yes,
or
sir.
ductal or fibrocystic disease or ductectasia.
Yeah.
The question are so simple and so direct. So this is fat necrosis with some calcification sometimes happen in old age post-traumatic fat necrosis. Okay. Next question.
Okay. A 46-year-old man is admitted to hospital with a femoral shaft fracture that occurred suddenly whilst he was out walking his dog. On examination, there is no neurovascular deficit distal to the fracture site. He has a large firm nodule in the left lobe of the thyroid. There is no associated lymphadenopathy. What is the most likely underlying cause? Papillary thyroid cancer, follicular thyroid cancer, thyroid gland lymphoma, anaplastic thyroid cancer, medullary thyroid cancer. The answer is follicular thyroid cancer because of hematogenous spread.
Okay. Other answers? All agree?
Yes.
Yes, follicular carcinoma. No lymphadenopathy.
Yes.
And there is pathological fracture, so hematogenous
So it is
spread.
okay. Exactly. What we discussed in our last session about the
And
most
there is
he will
a
ask you about.
nodule. Yes, nodule. Present as a nodule.
Exactly. The most common presentation for and type spread for most cancers, and we agreed all that follicular thyroid cancer spread via
Hematogenous spread.
hematogenous, and we just reminded by follicular red, so it will be hematogenous, and then we said papillary and medullary most commonly by
Lymph node.
lymphatic, so it is papillary ends with Y or medullary ends with Y, so
Yes.
it is mostly by lymphatic, and anaplastic
Locally infiltration.
local infiltration or direct invasion is the most common presentation for this. Okay, next question.
23-year-old woman presents with greenish nipple discharge on one occasion. Clinical examination of the breast is normal. Ultrasound is U1. What is the best course of action? Arrange mammogram, undertake total duct excision, undertake microdurcectomy, reassurance discharge, express duct fluid for cytology. I'm between D and E, reassure or fluid cytology. But
Your answer is
E,
E,
fluid
reassurance.
cytology. No, fluid cytology.
E, fluid cytology.
Yes.
Duration discharge on one occasion. Clinical examination of the breast is normal. Ultrasound is U1. What's the best course of action? So from where? So you will get the fluid cytology.
That's why I was confused between D and E, because it's
Yes.
one occasion.
Exactly. I think I told you from the start, from the previous question, we have two scenarios about the greenish nipple discharge you will face. One, he will tell you once, and there is no other manifestation, and there is no recurrent discharge, and you will go for reassurance, And then the other scenario is recurrent and trying multiple treatment and so you have to go for intervention. So that's why we choose here reassurance and discharge. And even he told you just one time, so you don't already have any cytology, any fluid for cytology, and he told you here it will be unhelpful as well. Okay, this is the two scenarios, by the way, don't confuse yourself by any other scenarios.
Okay, thank you, Dr.
Okay, next question. Dr. Ghada.
Okay. 52-year-old woman presents with a neck swelling. Her GP reports that her TSH value is low at 0.01. A scintigraphy demonstrates a hot nodule. What's the most likely diagnosis? Graves' disease, toxic adenoma, papillary thyroid cancer, Hashimoto's thyroiditis, decalvans, thyroiditis. Then TSH is very low. It's thyrotoxicosis. There is a hot nodule. It's a toxic adenoma because in Graves' disease there is diffuse swelling. There is no feature for cancer or thyroiditis.
Yeah.
So B, toxic adenoma.
Exactly. So by imaging scintigraphy, you find hot nodule, and that's what is the code of the low TSH. So it is a localized or hot nodule, not a generalized thyrotoxicosis, just a toxic adenoma. Papillary and Hashimoto's thyroiditis will be generalized if it is in its hypertoxic stage, or hypoxic stage, or hypotoxic stage. It will be cold and will be generalized. Decalvans thyroiditis also the same. The only one that gives you a hot nodule is the toxic adenoma. Okay, you have two localized lesions here, which is B and C, and both can give you a nodule. B will give you a toxic, a hot nodule, and C will give you a cold nodule, by the way. If he told you cold nodule, it will be papillary. Any cancer will be hypo. Okay, others, Graves', Hashimoto, and decalvans, this is generalized lesions, will not give you a hot or cold nodule in the scintigraphy or in the imaging study. Okay.
Yes.
So by exclusion, you'll just between B and C. C will be cold, B will be hot nodule. Next question.
A 55-year-old lady has undergone a wide local excision and sentinel lymph node biopsy for breast cancer. The histology report shows a completely excised 1.3 centimeter grade 1 invasive ductal carcinoma. The sentinel node contained no evidence of metastatic disease. The tumor is estrogen receptor negative. What is the next course of action? Monitor in clinic with annual review and mammography. Arrange radiotherapy, arranged combined chemotherapy, arrange chemotherapy, and prescribe anti-estrogen.
So you choose?
A.
A, monitor in clinic with annual review.
Yes, sir.
So this is an old lady.
I think B, radiotherapy.
It's grade 1 completely excised with
I think it's either radiotherapy or combined chemoradiotherapy.
Why combined? Why chemo?
If it's just wide local excision, so we need to complete with radiotherapy, and
Yes.
it's receptor
Radiotherapy.
negative.
I accept radiotherapy, but it is receptor negative and lymph node negative.
Yes. So I think for receptor negative, you can add chemotherapy.
Yes, I think chemotherapy, radiotherapy. Only
Sorry,
radiotherapy.
receptor negative.
I don't know, but I just remember that if case with receptor negative, we may add chemotherapy. I don't know. I'm not so sure.
Any other opinion?
Range radiotherapy. Only.
Radiotherapy. Okay. Radiotherapy. We said we just want to be just more clear, and he wants to give you questions are more district and no confusion and no coverage between two questions. You find no interaction between two questions. Want to tell you
Yes.
in any question, any wide local excision with negative
We
lymph
need to
node,
complete.
you just to go just local radiotherapy, complete local radiotherapy, because recent studies say that wide local excision with radiotherapy gives the same results and survival rate, the same as the radical mastectomy and so on. Okay, and radiotherapy as well. He want to tell you that if I have a lymph node positive, you have to give a chemotherapy. If I have estrogen and or progesterone, you have to give tamoxifen or letrozole or aromatase inhibitor. If you have HER2 positive, you have to give Herceptin or trastuzumab. Really, he will be so clear. So clear. The last scenario, he tell you that she is lymph node positive and the mass completely excised, and he gave you a chest wall irradiation. No, he just tell you arrange radiotherapy because he give localized radiotherapy, by the way. Local radiotherapy to the breast or to this tissue only, or part of the breast tissue only. They don't give generalized breast radiotherapy. Okay, so he will be concise and will be more care to tell you the precise information. Okay?
Okay.
All questions are clear. Don't confuse yourself. As we said,
Yes.
wide local plus radio, lymph node plus chemotherapy, estrogen progesterone plus tamoxifen or aromatase inhibitor, HER2 equals Herceptin or trastuzumab. Nothing more. Okay. Only one question we'll find in recalls. The patient is HER2 positive and she has positive lymph node. She will receive Herceptin plus chemotherapy.
Chemo.
And this, by the way, this question I think repeated in 2018 April and in April 2019 as well. Okay.
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 Herceptin plus chemotherapy. Okay, next question.
Okay. A 72-year-old female presents with pairless breast lump. Clinically, she has a 4 cm diameter irregular breast mass with no other palpable masses. What is the most likely lesion? Invasive ductal carcinoma in situ, lobular carcinoma in situ, invasive lobular carcinoma, atypical ductal hyperplasia. Okay. This is invasive ductal carcinoma.
Okay. He wants to ask you here. He gives you no data about any special type of cancer. Okay. He just wants to tell you what is the most common single mass breast cancer in old age in females. Okay. Ductal carcinoma in situ will not be palpable. Lobular carcinoma in situ will not be palpable. Invasive lobular carcinoma will be palpable, but with exception. What do you expect? if we have here two choices close, invasive ductal carcinoma or invasive lobular carcinoma. What is the difference in scenario? What is the difference in scenarios that you can choose go for invasive lobular carcinoma?
Most common than invasive lobular, this is number one.
Invasive ductal is the most common.
Yes.
But he just
The other palpable masses will get lobular.
no other palpable masses.
Yes.
Okay, he just want to give you, yes,
Yes.
mostly lobular carcinoma in this age will be multifocal bilateral.
Yes, exactly.
Yes, sir.
Okay, multifocal bilateral, and he want to give his question, no doubt. By the way, sometimes in the after the exam, some questions are omitted from the exam, so you can find your results maybe 250 from 295, and this is the maximum result of the exam. In spite you have 300 questions, because after the exam, when they find some questions are confusing, they omit it from the exam. I don't know exactly what is the rate and what they do, and even some in the Royal College who do the exam and do correction, they have what's called like algorithm or something like data collection, and how they can make some questions with a very low rate of right answer and confusing question with after they make like a meeting, and some questions are omitted, sometimes up to 5, 6, 7 questions are omitted from the exam. They are confusing and not accurate and not clear. Like here, if he, with no other palpable masses, if he didn't add this, mostly invasive ductal carcinoma, but lobular carcinoma inside, invasive lobular carcinoma may be right, okay? So just he want to be more accurate in his questions, not more, okay?
Yeah.
The only idea he wants to tell you here is invasive ductal carcinoma is the most common malignant tumor in old age in females. Okay, next one.
It's me now.
Okay, who was last
Thank you,
question?
Shane.
Okay, Dr. Ghada, go.
Okay. A 44-year-old lady presents with a mass in the upper outer
Sorry.
quadrant of her right breast. Imaging, histology, and clinical examination confirms a 1.5 cm malignant mass lesion with no clinical evidence of axillary nodal disease. What's the most appropriate treatment? Radical chemoradiotherapy alone, excision biopsy, and sentinel lymph node biopsy. Wide local excision and sentinel node biopsy, mastectomy and axillary node sampling, wide local excision and axillary node sampling. So it's 1.5 centimeter, it's less than 4, so not for mastectomy, no clinical evidence of axillary node disease. We may go for sentinel lymph node biopsy. So C, wide local excision and sentinel node biopsy.
Exactly. I think it's clear now why we didn't choose this.
Yes.
We just said a brain algorithm last time. When you don't have just the mass, you have to go for a biopsy to confirm your diagnosis. If it is not proved to be malignant, so you can go for excisional biopsy. If it is proved for be malignant, you go for wide local excision. If it is small and not in the center and it is just periphery and no other lymph nodes. Okay.
Okay.
Going for the lymph node, you have two ways. If you find it palpable or you see it by ultrasound, you will go for fine needle aspiration cytology. Okay. If
Okay.
it is palpable or you can see it by ultrasound, you will go directly for fine needle aspiration to make sure is there any malignancy or not.
Or
If it is malignant, you will go for excision of the lymph node or axillary clearance. If you can't palpate or you can't see it by ultrasound, intraoperative, you have to go for central lymph node biopsy. And mostly we do it by frozen section intraoperative to make sure if it is malignant and carrying malignant cells, we go for clearance. If it is not, we just remove this central lymph node biopsy only. Okay, so there is no radical.
Yes.
Excisional biopsy, no, it is confirmed to be malignant. If it is not confirmed, we can go for it. Wide local excision, yes. Central lymph node biopsy, yes. Mastectomy and axillary node clearance, no, not logic. And we don't know mastectomy for 1.5 centimeter malignant in the upper outer quadrant. Wide local excision and axillary lymph node sampling, no. More accurate to go for central lymph node biopsy or sampling. Okay, next.
Which of the following is not true for follicular thyroid cancer? They often appear to be encapsulated. Those with Hurtl cell subtype have an excellent prognosis. Hematogenous metastasis is more common than papillary carcinoma. The overall mortality is 25%. Vascular invasion is seen up to 60% of cases. Hurtl cell subtype has excellent prognosis. It spreads by hematogenous route. It has vascular invasion is seen in 60%.
Yes.
Mortality, I'm not sure about how much percent it
By
is.
exclusion, sometimes yes.
Yeah.
Most. Yeah, I said most big, but we have some question. When you give you some rates, mostly not all doctors and not all physicians and not all even surgeon know exactly the death rate. But sometimes I did see some questions that gives you a very high rate. Maybe the mortality rate is 5% and he tell you 90% or 80%. But when you see a rate, mostly this answer will be right. Mostly, I'm not saying it is sure to be answered. Mostly any rates he will give you, you have to exclude it because in the exam he don't want you to know many calculated information and many rates, except for the most common or very common diseases. But here he wants vascular invasion is up to 60%, mostly right. The overall mortality is 24, mostly right. Okay.
Yes.
No calculations in the exam will be, and they don't want to ask you about rates. So when he give rates, he's just trying to put answers, right answers, to complete the choices. So they often appear to be encapsulated.
جيب لي واحدة
Yes.
كنابون ايه رأيك؟
أنا عايزة كنتالوب باي.
Okay.
Yes.
Often to be encapsulated. Yes. Hurtl cell subtype have an excellent prognosis. Maybe I'm not sure. So go for the third one. Hematogenous metastasis is more common than in papillary carcinoma. No.
Yeah.
Okay. Yes. Sorry. It's right. So it is not the answer. So most commonly will be B. Number B will be the answer by exclusion. And this is a way of thinking in the exam. You will find many questions very new, but you will exclude one or two answers completely away from the right answer, sometimes 3 answers, and you have a choice between 1 or 2, and you will go for one answer from the first time. Okay.
Okay. Yeah.
Next question.
Okay. Administration of which of the following may facilitate the identification of parathyroid glands intraoperatively? Patent V dye intravenously, methylene blue intravenously, indigo-chromin dye intravenously, India ink intravenously, intravenous rifampicin, methylene blue intravenously.
Sorry. You hear about methylene blue. Yes, methylene blue is the most common we use.
Yes.
Intraoperative to identify parathyroid glands. Okay. So I just unmute myself. Next question. Sorry, it is answered. I forget to add the answer. The question. So anyone just read the question and we know it, and then go for the next question as well.
Okay. 59-year-old lady undergoes breast reconstruction following a mastectomy. A breast implant is placed anterior to pectoralis major. What is the most appropriate method of wound closure? It's answered pedicle mycocutaneous flap. But as there is implant, you can't add graft, skin graft, as there is no good blood supply pedicle. So we will use flap. And here pedicle flap, I'm not very good at types of flap, so let's see.
Okay, we used to for reconstruction to use pedicle mycocutaneous flap like tram. Sometimes we take the rectus abdominis flap, or sometimes we take latissimus dorsi flap. Okay, this is pedicle mycocutaneous flap. Okay, use one of them, by the way, even the rectus abdominis or the latissimus dorsi flap. This is the only flap we use for breast cancer till now. Okay.
Tram flap is used when there's the defect is large.
Exactly, because we have a big muscle, and it is limited graft to take from the anterior abdominal wall.
Yeah.
He will not ask you about this difference, by the way. Just he don't want you to be an excellent or professional plastic surgeon about this. Okay, next question. The same. You can continue, Dr. Brahim. I think you can continue. Yeah.
A 38-year-old man is noted to have blood pressure 175 over 110 on routine screening. On examination, there are no physical abnormalities of note. CT scanning shows left-sided adrenal mass. Plasma nephrins are elevated. What is the most likely cause? Pheochromocytoma. C.
Exactly. We talked before about the adrenal mass, and we said when you find most adrenal masses, you find it incidentally during ultrasound, during CT, during MRI. What you do if it is less than, I think I can remember, if it is less than 4 centimeters, you just go first for blood analysis for the serum or plasma catecholamines, and if it is clear, it is free and it is normal, you just go for surveillance or follow-up of the mass. Okay, because most masses of the adrenal gland are benign. Okay, This is a protocol for any adrenal mass, except especially if it is small mass, like 1.5 centimeter or something like this. Mostly are benign masses. So what you go, the next step you go for, because I think we have this question or we didn't have yet. The next step after you find this mass, you go for testing the blood for catecholamines or metanephrines or the urine as well. If you find metanephrines or catecholamines high, so you are facing a pheochromocytoma. If you find it normal, so it is a benign mass. Okay. Next question. Together.
Okay. 21-year-old female notices a bloody discharge from the nipple. She is otherwise well. On examination, there are no discrete lesions to feel, and mammography shows dense breast tissue, but no mass lesion. What's the most likely cause? Intraductal papilloma, breast abscess, ductectasia, fat necrosis, cyst of Montgomery's gland. Most common, it's intraductal papilloma.
Exactly, bloody discharge in a young patient, 25, mammography normal, no distinct lesion, no, by examination she is free. So it is ductal papilloma. Duct breast abscess will not give you a bloody discharge. Ductectasia is the same.
Greenish.
Will give you greenish pasty discharge. Fat necrosis, no. And cyst of Montgomery, this is, I think this is cutaneous, I think, problem. Montgomery's gland of the areola. This is not, will not give you the blood discharge. So this is intraductal papilloma. If the age is old age, so you have more to doubt about cancer breast. Yes, and he, by the way, here even maybe malignancy has a rate of 1 to 5%. So he didn't put any malignancy in the choices here because maybe right, she have malignancy. You can't exclude malignancy in this case, but he didn't put malignancy. He put the most common possible diagnosis in this case. Okay, yes. Next question.
A 53-year-old lady presents with a creamy nipple discharge. On examination, she has discharge originating from multiple ducts and is associated with nipple inversion. What is the most likely diagnosis? Cause: ductal papilloma, ductectasia, DCIS, LCIS, and tuberculosis. So creamy nipple discharge mostly goes towards ductectasia.
Exactly. Greenish discharge is associated with ductectasia. And what is the operation we do for it?
Hatfield operation.
Hatfield operation, exactly.
But
and what we do for, yes?
Ductectasia, does it cause nipple inversion too?
Sometimes from periductal fibrosis.
Okay, thank you.
What is ductectasia?
Dilatation of the ducts.
Non-specific.
Chronic inflammation.
Chronic inflammation.
Well,
with high lymphocytic infiltration and periductal fibrosis. Periductal fibrosis. Sometimes it makes like dimpling or slit-like dimpling, as Dr. Ghada said, in the nipple and sometimes in the areola. Okay, and sometimes when you feel it, by the way, sometimes, and it happened with me one time, if the breast is soft and the skin is floppy, sometimes you feel the fusiform dilatation, by the way.
Yes,
it's like
exactly.
Fusiform dilatation. You can feel it by hand, by rolling your hand. You can find it. Sometimes you can see it by the ultrasound, and you can find it if the breast is soft, floppy, and the skin is shrinking and soft breast,
Yes.
sometimes you can feel the fusiform dilatation, by the way, and you can squeeze it and get some discharge from it. Okay.
Yes, exactly.
Okay, next question.
Okay. A 56-year-old lady undergoes a mastectomy as treatment of multifocal ductal carcinoma in Cyto. 2 weeks post-operatively, she attended the clinic and complains of diffuse swelling at the same. On examination, she has a large blood area underlying the mastectomy skin flaps. She is otherwise well. What is the most likely cause? Abscess, seroma, hematoma, disease recurrence, arteriovenous malformation. Okay. Seroma?
Yes.
Exactly. From the scenario here, you have 5 choices. Abscess, maybe. Seroma, maybe. Hematoma, maybe. Okay.
Yes.
Disease recurrence, not after 2 weeks. AV malformation is not after 2 weeks, and there is no AV malformation will happen in the surgical site of mastectomy. Let's go for the scenario again. 2 weeks post-operative, she complains a diffuse swelling around the surgical site. On examination, she has a large fluctuant area.
Yes.
She is otherwise well. So if it is an abscess, do you expect with a large fluctuant area, she will be well?
Yeah,
She will be febrile.
Febrile and feeling unwell. If it is a
Yes.
hematoma, she will be well?
No.
No. Painful.
Painful, pale, weak, drowsy.
Faint.
Maybe some
Changes
fainting
over the
attacks.
skin.
Maybe
Discoloration,
color discoloration of the skin. Exactly. So the first 3 answers is right, but he excluded 2 of them by she is otherwise well. Okay. So
Yes.
put in your mind these small words sometimes give you the key for answer. So seroma, and it is the most common swelling we find after mastectomy, especially when you do clearance of the lymph node, because you are removing all the lymphatic vessels. So seroma, if exactly also if you remove the drain
yes.
early, before you make sure that no or just little less than 50 cc coming, or 40 to 50 cc coming in the drain, so you can remove it. If you removed it early or you didn't put a drain, you will have this seroma mostly 100% after your operation. Okay, so seroma is the most common problem you face in the wound in patient after mastectomy. Okay, clear?
Yes.
Clear, yes.
Next question.
An 88-year-old lady presents with a large mass in the upper inner quadrant of right breast. Investigations confirm an estrogen receptor positive invasive ductal carcinoma. She has declined operative treatment. What is the best course of action? Combined chemoradiotherapy, radical radiotherapy, administration of letrozole, best supportive care, chemotherapy alone, estrogen receptor positive and no operation, so hormonal therapy. So I will go with C.
Okay, letrozole, so a large upper inner quadrant right breast, investigation for estrogen receptor invasive ductal carcinoma. She has declined operative treatment. What is the best course of action? You will give letrozole. Okay, so I think straightforward, as we discussed before. Okay.
Yes.
Mostly in 88, sometimes they do simple mastectomy and sometimes they don't do operation, by the way. In this age, maybe operation and anesthesia is more dangerous for the patient than let the patient die in peace. And if the patient is just recently discovered invasive ductal carcinoma, the low estrogen in this patient and in this age, the spread of cancer is very slow. So the life expectancy without with the operation may be the same or more more as operation, or maybe the operation may be risky for the patient. By the way, we meet many patients about 85 to 90 years and have this operation. Just let the patient die in peace. Doing an operation, maybe you have infection, problem, seroma, wound will not close. The patient will go for surgical problems and more risk, more than you let the patient die in peace. So sometimes you give letrozole, sometimes you give nothing, and just follow up for the patient. Okay. Okay, but here is administration of letrozole because maybe in Europe and UK, 88 is starting old age. Sometimes this is the start of old age, but in our Arabian country, you start old age maybe after 40. Okay.
Okay.
Okay. Next. Who's there?
I have died yesterday or what is it now?
Okay, Dr. Hada, go continue.
Okay. You are the specialist trainee in endocrinology clinic. The medical team have referred the man for a parathyroidectomy who has a corrected calcium of 2.82 elevated and PTH of 11 elevated. Which of the following is not an indication for parathyroidectomy in this case? Nephrolithiasis, reduction in bone mineral density of femoral neck, lumbar spine, or distal radius of more than 2.5 standard deviations below peak bone mass, age is less than 50 years, episode of life-threatening hypercalcemia, or none of the above. So it's asking about not an indication. All of these are indication: nephrolithiasis, the age, the hypercalcemia, even reduction in bone mass. So none of the above.
Exactly. All these are indications and important indications for parathyroidectomy in any patient: nephrolithiasis, a reduction in the bone mass density, or age, still young age or middle age, and episode of life-threatening hypercalcemia. All of these situations is indications for parathyroidectomy. Okay, next question.
A 34-year-old lady admitted with recurrent episodes of non-specific abdominal pain. On each admission, all blood investigations are normal, as are her observations. On this admission, a CT scan was performed. This demonstrates a 1.5 centimeter nodule in the right adrenal gland. This is associated with lipid-rich core. Urinary VMA is within normal limits. Other hormonal studies are normal. What is the most likely diagnosis? Malignant adrenal adenoma, pheochromocytoma, metastatic lesion, benign non-functional adenoma, benign functional adenoma. So it is D, benign non-functional adenoma.
Benign non-functional adenoma. Yes, this is one of the feature I forget to mention when I told you when you find a mass. If it is small and the CT gives you a lipid-rich core, this is for sure a benign non-functional adenoma, and this is not an excuse not to have or not to do a blood test or urinary test. Okay, any mass you have, it is small and lipid-rich core, mostly benign. Your next step is a blood test or the urinary test. You will search for catecholamines and vinyl mandelic acid, which is one of the metabolite products of catecholamines. Okay,
Catecholamines.
so if they are normal, so you are facing a benign non-functional adenoma, and this is very common in the adrenal gland. Okay,
Yes, sir.
if you find them high, so you are facing a pheochromocytoma.
Yeah.
If it is more than 4 centimeters, I think that you have to doubt malignancy and you have to go for, sometimes they say biopsy and it is unlogic. Sometimes you go direct for adrenalectomy. Okay.
Okay. Yes, sir.
Next question.
Okay. A 32-year-old Indian lady presents with a diffuse swelling of the left breast. She has a 4-month-old child. Clinically, she has jaundice, and there is erythema of the left breast. Which of the following lesions is most likely? Phyllodes tumor, radial scar, invasive ductal carcinoma, invasive lobular carcinoma, inflammatory carcinoma.
What do you think?
Inflammatory carcinoma.
Okay. What's your key point here or keyword?
Redness and jaundice.
Yes.
Okay.
And she's
Jaundice is the
young.
most important. Yes,
Yes.
jaundice is the most important. In a lactating patient, you have to face 2 problems.
Abscess.
Most common is the breast inflammation or breast abscess or mastitis. Not abscess is a stage of mastitis. You have to go for mastitis, and the other one is inflammatory carcinomatosis. Okay. Here he didn't mention any abscess, by the way, because maybe it's a little bit confusing. Okay, so he didn't mention abscess at all, and he just mentioned inflammatory carcinomatosis. Okay, but the most common problem in lactating women is mastitis, and I think the 3rd stage of mastitis is the stage of abscess formation. Okay.
Yes.
Okay.
Next question.
A 52-year-old woman presents with a neck swelling. On examination, she is noted to have a single nodule on thyroid gland. Chest X-ray shows 2 mass lesions. What is the most likely cause? Papillary thyroid cancer, toxic adenoma, follicular thyroid cancer, anaplastic thyroid cancer, medullary thyroid cancer. I guess follicular thyroid cancer and hematogenous spread to lung.
Okay.
C.
Other opinions?
Follicular, yes. Hematogenous spread, and there is a nodule, so follicular.
Exactly. This age, 52, this is follicular. Okay. We said papillary, mostly if papillary and the medullary, mostly with lymph node lesions, and have mostly will be lymphatic spread. Anaplastic will be mostly localized, and it's more higher age. We find it more than 70, 80, something like this. Toxic adenoma, the patient will have no X-ray, and she has no manifestations of any toxicity, and there is no relation between the toxic adenoma and the 2 masses in the chest X-ray, because it's mostly the swelling in the mass in the neck. If it is cancer, it will not be toxic, it will be a cold nodule. Okay, so it is a follicular thyroid cancer, straightforward. Hematogenous equals follicular. Neck lymph nodes or lymphatic equals mostly papillary or sometimes medullary. But medullary, the scenario will be different. He will ask about mostly the familial type of medullary carcinoma, about a young age and family history, and bilateral and multicentric. Mostly, he will not ask you about the sporadic, because the sporadic is confusing with the papillary and follicular, by the way. He will not ask you about the sporadic medullary because it's confusing with the papillary, because both of them have lymphatic spread. And the picture, the same picture with the follicular, if you talking about a nodule in the neck, on thyroid nodule. He will ask you about the familial type and the Men's syndrome, whatever it was associated with pheochromocytoma or other disease, or he will tell you she has a family history. Her sister, her mother in a young age have this problem, or calcitonin is high, or something like this. Okay, next question.
A 55-year-old woman complains of nipple discharge. This was blood-stained on one occasion, but not subsequently. Clinical examination shows clear fluid, but no discrete clump. Imaging with ultrasound and mammography is normal. What's the best course of action? Mastectomy, total duct excision, microdocotomy, discharge, mammographic surveillance. It's not mastectomy or discharge or mammographic surveillance, so we have either total duct excision or microdocotomy. Just for one occasion, clear fluid, no lump. The imaging is normal, so microdocotomy, it may be intraductal papilloma.
Any other answer? You choose C.
I think
Any
C.
other opinion? Okay.
It's most probably intraductal papilloma.
Yes.
And so we will do microdopectomy.
Okay, exactly.
Yes.
This age, maybe 55, so microdactyctomy is maybe it is done mostly for as a biopsy or as a confirmation it is not a cancer. So you can discharge the patient, okay? You can't do mastectomy, you have no proof. Mammographic surveillance in a 55-year-old patient with bloody nipple discharge is not logic. Total duct excision, we don't have any operation. We know that what's called total duct excision. We have what's called microdactyctomy, we do it back to papilloma, and for the old age, we do it as to exclude any malignancy in this patient, which is mostly will be malignant if it is the first attack. Mostly this patient may have maybe ductal carcinoma in situ or something like this. Okay?
Okay.
Next question.
A 48-year-old lady with thyrotoxicosis is referred to the clinic. She was poorly controlled on carbimazole and has received orbital radiotherapy for severe proptosis. This has improved matters, but she relapsed on stopping her carbimazole. What is the most appropriate course of action? Administration of radioiodine, subtotal thyroidectomy, external beam irradiation to the thyroid, hemithyroidectomy, or total thyroidectomy.
So you choose. So what's your answer?
As she is history of severe ptosis. I'm confused. Shall we go for radioiodine or not?
You'll go for radioiodine, but she already received orbital radiotherapy.
Yes, sir. Yes, sir.
For severe proptosis, so you'll go for so you'll go for radioactive iodine.
No, sir. I'm not sure.
Okay. Any answer?
I think total thyroidectomy.
Total thyroidectomy.
Exactly. This is a case of one of the indications of surgical treatment for thyrotoxicosis, failure of medical treatment, and contraindication of any radioactive iodine, which is the severe proptosis. Okay.
Okay.
Okay, so we have, if you remember, a very famous question, which is indications and contraindications of surgical treatment. Advantage, disadvantage is very common even in our bachelor degree and in master. What is the advantages and disadvantages of both medical and surgical treatment? Okay, so it was everyone and the reverse. So in surgical treatment, the advantage that you remove all the thyroid gland. By the way, subtotal thyroidectomy is a historical operation. We don't do it nowadays for any cause, even if it is not cancer, just for even thyrotoxicosis, because any recurrence or any problem will happen in the thyroid further, wise, it will be a nightmare for the surgeon to go again for completion of thyroidectomy. Subtotal thyroidectomy, disastrous, exactly. Subtotal thyroidectomy is historical operation. Even you leave it all or remove it all by its capsule. Going back again in the neck of the patient, so you are doing a disastrous operation and the patient or you will die after the operation. One of you.
Yeah.
Okay, so total thyroidectomy. Hemithyroidectomy we are not doing for thyrotoxicosis. Yes.
Just a question. What about lobectomy if it is for follicular in one lobe? Is it justified?
If you have only one mass, you don't leave in this. If you have one mass like nodule, you go for lobectomy, hemithyroidectomy. Okay, but if you have thyrotoxicosis or you have multinodular, before the best treatment for multinodular goiter is subtotal or near total thyroidectomy. Sorry, for subtotal thyroidectomy. Okay, to leave some thyrotoxic for the patient, and you give complementary or you give thyroxine. So as you are giving thyroxine, why you leave a part of the thyroid?
Yes,
and
exactly.
Multinodular goiter, maybe after 35 or 50 or 40 or 50,
will be
it
recurrent.
has a recurrence rate of about 15 to 20% of cancer to be transferred to cancer. Why you leave it? And the best was before historical for thyrotoxicosis, it would be near total thyroidectomy is the best course of action. But after the operation, if you found the patient is hypo, you will give thyroxine. If the patient is still hyper, you have to give carbimazole or go again for operation, because you can't decide intraoperative under surgery how much will you leave, and you can't do the test to make, is it part, it is sometimes like they say the tip of your little finger or something like this. It was some haphazard decisions. Now you go for total and give replacement therapy. Total and give replacement therapy. Okay, so this patient is failure of surgical and medical treatment, so you go for total thyroidectomy and replacement therapy. No rule for radioactive now because this patient have severe proptosis. No rule for subtotal. No rule for external beam irradiation for the thyroid. No rule for hemithyroidectomy in thyrotoxicosis. And total thyroidectomy is the best choice here. Okay, next question.
Okay.
Okay, a 55-year-old woman presents with nipple discharge. On examination, she has slit-like retraction of the nipple in the center of this area. It's a small amount of cheese-like material. No discrete mass lesion is palpable in the underlying breast. What is the commonest underlying cause? Invasive lobular carcinoma, ductictasia, fibroadenoma, keloid tumor, inflammatory carcinoma. This is ductictasia.
Okay, we will not discuss it more than this.
Yes.
We just discussed it many times. In the exam, you do the cheese-like material. Go by your eyes direct for the answers and choose ductictasia. He will not confuse you in the exam and give you rare possibilities like cancer, okay, or abscess or chronic abscess. No, he will give you direct. He wants you simply to know cheese-like material is ductictasia. Okay.
Okay.
Next question.
Which of the following statements regarding papillary carcinoma of thyroid is false? They account for the majority of thyroid carcinomas. Yes. Spread predominantly via the lymphatics. Yes. May be diagnosed using the needle aspiration cytology. I'm not sure. When viewed microscopically, may demonstrate orphan nuclei. Yes. Have a 5-year survival of 65% if confined to the thyroid alone. I'm between C and E. About fine needle aspiration cytology, there is one can be distinguished and papillary and follicular. I guess fine needle aspiration
Till you can be
diagnose
diagnosed.
papillary. Yes,
Can be diagnosed papillary. Yes.
But can't diagnose follicular.
Sometimes can diagnose follicular.
So the answer
Sometimes
is E.
can't.
Okay, thank you.
By exclusion is E. By exclusion is E. 5-year survival rate here is high, and this is the question I told. Sometimes the rates may be the answer, but mostly he will not ask you about the rates. But here is the papillary carcinoma is the most common cancer in thyroid, and it's if it is localized and not metastatic, 5-year survival rate more than 90%. And even by exclusion, he gives you all the answers are directly right. Majority, this is the most common cancer, spread by lymphatics, fine needle aspiration can diagnose, yes. Even follicular, by the way, fine needle aspiration can diagnose, but he wanted to tell you to put in mind, and if he want to ask you a question in the exam, he will tell you that fine needle aspiration mostly can diagnose follicular. Why? Because of the perivascular and capsular invasion. Okay, but sometimes it can diagnose, by the way. But sometimes you need to go for hemithyroidectomy to confirm the diagnosis. Microscopically may demonstrate orphan nuclei. Yes. Okay. Next question.
A 55-year-old man is on the intensive care unit for many months after open aortic surgery. He is maintained on total parenteral nutrition. Clinically, he is euthyroid, but his thyroid function tests reveal a low TSH and low T4. What is the most likely diagnosis? Iodine deficiency, Hashimoto's, hypothyroidism, sick euthyroid syndrome, multinodular goiter, sick euthyroid syndrome. Both
Exactly.
TSH and T4 is low, and he is after aortic surgery, so sick euthyroid syndrome.
Okay, post-operative in intensive care unit, and has all tests for the thyroid are low. So this is clearly the sick euthyroid syndrome, and it will come in the exam like this, very clear. Okay.
Okay.
Next question.
35-year-old woman has undergone a wide local excision. The histology shows an invasive lobular carcinoma present at 3 of the resection margins. Cavity shaping taken at the original operation are also involved. Sentinel node biopsy was negative. What is the most appropriate course of action? Arrange for re-excision of margin, arrange for breast radiotherapy alone, arrange for completion mastectomy alone, arrange for radical radiotherapy to the breast and axilla, arrange for completion mastectomy and axillary node clearance. So they are saying that the 3 margins are involved, and one is 3 margins are free and one has still the positive tumor.
So the margin of the mass is positive, but central lymph node is negative.
Negative.
So simply, what will you go for?
Re-excision of
And
the
this is
margins.
proved to be lobular carcinoma, invasive lobular carcinoma. So it is multicentric and maybe bilateral. So what will you go for?
Completion
Do you
of
have any rule
Mastectomy.
for axilla here?
No.
Any rule for the axilla
No.
here? So the last 2 questions, the last 2 answers are completely wrong. Okay, we don't
yes.
have any rule for the axilla here. Do we have anything called re-excision of the margin in the breast?
No.
What will you leave and what will you take?
See, complete
We don't have.
completion.
So we are between breast radiotherapy alone and arrange a completion mastectomy, and radiotherapy without removal of the original tumor is unlogic.
Yes.
You'll go for completion of mastectomy.
Yes.
Yes, lobular
Okay.
carcinoma, not ductal.
Okay, this is invasive lobular carcinoma. So it is multifocal. So you will do completion of mastectomy. No rule for the axilla. He confirmed that axillary lymph node biopsy is negative. Central lymph node biopsy is negative. But if it is positive, you will go for number E. You'll go for completion of mastectomy and axillary node clearance. Okay.
Okay.
But it is negative, so no rule for the axilla here. You just go for completion of mastectomy. Simply. Okay.
Yes.
I think this is the last question. Dr. Ismail, Dr. Fahim.
Okay, sorry.
Oh. Okay, Dr. Ismail.
Which investigation? Okay, I'm sorry. Which investigation is best for initial assessment of recurrence of follicular carcinoma of the thyroid? Free T4 thyroid stimulating.
Okay, without reading the answer, which is
serum thyroglobulin.
Okay.
Serum thyroglobulin.
I think this is a repeated question. Serum thyroglobulin is the only indicator for the recurrence of any cancer of thyroid after complete thyroidectomy. Thank you. We finished our discussion today. It's about less than 2 hours, maybe. Yes, we didn't go for 2 hours. Thank you for participation. Thank you for discussion. Hope you enjoyed our discussion. Hope it is rich and beneficial for you. I'll close the recording now just to
Okay.
not to make the recording so long.
Thank you very much, Dr.